Chương trình thì có Phó Giáo sư Tiến sĩ Lê Thanh Dũng và tôi là bác sĩ Ngô Huy Lâm ở bệnh viện K. Thì chúng ta bắt đầu cái phiên báo cáo về vấn đề về abdomen imaging. Thì để bắt đầu của chương trình thì tôi xin kính mời tiến sĩ Quek của báo cáo viên từ Singapore. Xin mời báo cáo viên. Trong thời gian chuẩn bị thì tôi xin chia sẻ là hiện tại là ông Quek là chair của hội điện quang can thiệp và cơ quan can thiệp chuẩn đoán ảnh và cardiology của Singapore. Vâng, xin mời.
Hello. Oh, hi. Thank you for coming. Da Nang is a lovely city. I'm Dr. Lawrence Quek from Tan Tock Seng Hospital, Singapore. And today I've been asked to talk about Barcelona guidelines update on the paper published in 2022. A little bit dated, but still will be nice to go through. And the patient selection for radioembolization and how we treat them even before and with the guidelines in comparison. We'll do some clinical case sharing. So just looking back, this is a publication back in 2003. Love that published in Lancet, basically the BCLC guidelines for treatment. And when you look at the HCC treatment, they distribute it or categorize into 5 different stages, okay? From the very early stage 0 with 1 HCC less than 2 centimeter, moving on to early stage A with 1 HCC or 3 nodules less than 3 centimeter with a good performance score. And then moving on to intermediate stage B, multinodular, but also a good performance score. And then you have the advanced stage where there's portal invasion, nodal and metastasis, nodal involvement and metastasis, and eventually the terminal stage D. So if you look at the very early stage and the early stage, stage 0 and stage A, primarily it is a curative intent. So patients in this category, we're looking to cure the patient. And when you move on and you look at this, right, back in 2003, the curative intent is resection for very small HCC less than 2 centimeter. And then after that, you move a little bit to the right of the chart, and you're looking at a palliative intent. So there will still be treatment, but there's palliative intent in that sense that we're not looking to cure the patient, but to prolong survival and also to relieve symptoms. So chemoembolization was one of the techniques back then in 2003 in interventional radiology, where there's a lot of meta-analysis that show that it confers survival benefit. So it's a level 1 evidence for chemoembolization. Now, you fast forward 15 years, in 2018, we have Fauna, which published in Lancet again. This time round, they have collected more data based on the BCLC guidelines. And with the data that's come through, they are able to better prognosticate what we are doing with our treatment in both the early stages as well as the intermediate to late stages. So in the early stages, we are looking at more than 5-year survival benefit if you do the treatment correctly. And when you're looking at the stage B to terminal stage, we're looking at somewhere between 3 months to 2.5 years. Now, it's interesting how 15 years later, with the advent of ablation and how the techniques have improved with more experienced operators, we're looking at, with very early stage, that ablation has become the gold standard as far as treatment is concerned. Certainly some centers will still do resection, but these are ablation for patients that are not considered for transplant. Because if you are considered for transplant, then it's a different thinking altogether. Okay, and chemoembolization still remains in the intermediate stage B in these patients with good performance score. However, there's a caveat: you must have good preserved liver function. Okay, so what is preserved good liver function is compensated liver disease, which is Child-Pugh A without ascites. All right, and but in clinical practice, we do have patients in stage B, Child-Pugh B. That are not really A, but we treat them with chemoembolization anyway because in the absence of getting systemic therapy, they have no therapy given for them. So, and back then in 2018, before the advent of immunotherapy, we have tyrosine kinase inhibitors like sorafenib and regorafenib, and those are not really kind of treatment that can treat the disease in the manner that people are excited about. Okay, in anything, it stabilizes the disease, but there's a 30% complications or side effects from the treatment of that medication. And our oncologist insists that the patient has to have good liver function, Child-Pugh A. Anything outside that, they are not considering the patient. So now let's look at the new BCLC guidelines, or not so new now, since it's 2022. And this was an update by the same author in a journal of hepatology. So it's a little more complex now, given this chart, okay? And so I'll take you through slowly. So what has changed? We're talking about a new concept of treatment stage migration. And what does that mean? It means that based on the patient's specific patient profile, like comorbidities, age of the patient, patient values and availability, you may shift the recommendation from the left side towards the right side, which is more towards the right side of the chart, which is more for advanced patient, but you can use those techniques to treat the early stage patients. So in a very early stage patient, we're looking at ablation and resection primarily, okay? But sometimes patient cannot be on ablation or cannot have ablation or have surgical resection, and I'll go through some cases later. Then you can move forward and do TACE, all right? The next step was the introduction of radioembolization and transarterial chemoembolization for patients in the early stages. So if they are not feasible for ablation, resection, or transplant. So you're looking at the chart going downwards for the early stage patients using intra-arterial therapy, which was not something that was considered close to 2 decades back. So what has changed? I think I'll show some studies. So before we go into Y-90 per se, just the concept of radiation segmentectomy. So what is that really? It's basically giving an ablative dose, a high dose of radiation through the vessels, feeder arteries to the tumor, and big enough so that you ablate it and with a curative intent. Okay? And that was a concept that came out in 2011 and subsequently expounded further by many experts and authors. And there's a few assumptions. The model assumes that the area to be ablated in this sense using Y-90 is a very small area, and there is a homogeneous distribution of Y-90, which is not always the case when you implant in the tumor, because the tumor comes in different shapes and form and have different arterial supplies. So what exactly is the dose? And really in the last decade, dose has become really important in the treatment. You don't give enough dose, you're just tickling the tumor. Right? The tumor will be laughing at you. Right? You got to give enough dose, big enough to be able to obliterate the tumor. So we're looking at the dose of more than 190 grays for glass microspheres, and somewhere in the ballpark of 3 to 5 centimeter tumor. And that is largely based on the study published in 2014 by Wush. All right. What they did was they looked at 102 patients, of which 33 went for transplant. They took out the tumor and they had a look at it. And when they looked at it, they found that when the dose was more than 190 grays, there's a larger percentage, more than 2/3 of the patient had complete pathological necrosis, that's CPN. So this is where they pin it at 190 grays. Subsequently, on the back of another study, which I will talk about it just after this slide, the doses have moved up further. So we're looking at 400 grays for glass microspheres, and for treatment up to 8 centimeter. And this is on the back of the Legacy trial. The Legacy trial had a significant impact on the new BCLC guidelines with this retrospective study that they've done. It's a multi-site between 2014 to 2017. And basically, they want to evaluate the objective response rate and duration of response in patients with solitary unresectable HCC treated with Y-90 glass microspheres. So you're looking at lesions less than 8 centimeter that's unresectable. However, in the study, bear in mind the median tumor size is 2.6 centimeter. And to keep the study as homogeneous as possible, because as you know, in the treatment of HCC, it's a very heterogeneous population. To keep it homogeneous, everybody must be Child-Pugh A. All right, so we are not affected by liver function or the poor comorbidities of the patient. And what they found that, in conclusion, that there's clinical meaningful response rates and prolonged duration of response observed in the treatment of unresectable solitary HCC less than or equals to 8 centimeter. So this is a big study done by Riyad Salim and published in Hepatology in 2021. All right, so now, on radiation segmentectomy, and I know in Vietnam most people use resin rather than glass, and really they have different physical properties in model-based studies. They have physiochemical properties are different, but for resin microspheres, just to touch briefly on, is 150 grays to the perfused volume for resin microspheres. So why would we consider radiation segmentectomy over ablation or even sometimes a resection? So I think in the context of ablation, really if you're looking at capsular lesion up at the tumor, deep-seated lesions in the paracava near the IVC, all right, those are very hard to ablate and get good margins. So the concept of R0 resection, we talk about A0 resection, ablation zero tumor in the margins. You really do want to get up to 1 centimeter around the tumor of normal liver when you do your ablation to ensure that you don't come back with a recurrence. Now, with Y-90 delivery near the diaphragm, gallbladder, and blood vessels, and gastrointestinal tract, really at the end of the day, when you do that, it's actually relatively safe. So even if you give a high dose, you're not going to affect the adjacent organ that much. Now, size and shape of lesion is important. Not all the tumor read textbook. They don't come in one big round. They come in different shapes and sizes. So you need to do multi-probe placement for ablation to ensure that you get the margins. Patient's clinical status is important. Patients with multiple comorbidities, unable to tolerate general anesthesia, unable to withhold platelets or antiplatelets and anticoagulants, and also patient preference. With ablation, you can do under GA. We do some of our patients under conscious sedation, some under GA, but post-operative care, they do get a bit of pain. So, you know, some people want to avoid pain, prefer Y-90. Certainly cost is an issue. Ablation is cheaper than Y-90. And institutional preference. If patient is for transplant, then the fear of thread seeding by placement of needle probe is real. So then, this is a retrospective study published in Radiology. And if you look at it, solitary tumor up to 3 centimeter, radiation segmentectomy versus combined therapy of TACE and ablation, and with propensity score matching, the conclusion was after you matched it, the response rate, the complete response rate, and overall survival were not significantly different between the two groups. So radiation segmentectomy has proved its worth. It is non-inferior. And then further study by Atkins group, Mount Sinai, and we look at a prospective study now, also 3 centimeter tumor in unfavorable location. The numbers are smaller, but it shows that it works. They have given doses more than 2.5 times the legacy trial of 400 grays. We're looking at 1,000 grays for the median tumoral dose. They have shown that radiation segmentectomy is efficacious, is good. Low proportion of high-grade adverse events in these patients because it's very localized. And in patients, they are unresectable, very early to early stage HCC with suboptimal location for ablation. So now, we've just finished and done with that part of the literature. Let's look at some of the cases we have seen over the years. Here's an overseas patient, 76-year-old Asian male, had the recent coronary stent insertion to the LAD and recent mild ischemic stroke. Patients are aspirin and Plavix, high perioperative risk as judged by the cardiologist and neurologist. And you can see that he has a lesion over in segment 8. So was referred to Y-90, referred to us for and not suitable for ablation or resection. So since it's confined to a single segment, or as far as the images show, a single segment in segment 8, radiation segmentectomy was proposed. This is the CBCT on the left side. We also go and interrogate segment 4 because you are aware of the cross flow from segment 4 to segment 8, and the segment 4 shows there's no tumoral supply. So you can safely deliver the high dose at segment 8 and get the response. So we did the mapping, good liver lung shunt, and then 2.5 gigabecquerel was delivered, and this is the post Y-90 Bremsstrahlung study. Appropriate, not too high a dose to the lungs. We gave about 200 grays to segment 8, more than 190 back then at that thinking. And this is a 2-month follow-up, shows no arterial enhancement. So now we have the pre-Y-90 images at the top, which is here, and then 6-month follow-up shows the hyperemia around the lesion, but largely treated. Then 18-month follow-up patient came, all right, you still see a hypodense lesion, albeit smaller, with some calcification in it. There's a new lesion seen in segment 7. Okay, so same thing, this time a higher dose using spheres, resin microspheres, and then to follow up again, and you see the involution 7 months post Y-90 of the area that we have treated. So that's part for that patient. Let's move on to bridge to resection. So here's a 70-year-old Chinese male with segment 8 HCC compressing on intrahepatic IVC. So as you can see, okay, on the coronal images, the tumor is compressing on the IVC. Okay, so this is something that we're looking at as early stage A, and really at the end of the day, resection is contemplated for this patient. However, it is not suitable because the future liver remnant, FLR, is insufficient. Came out to about 31%. So the surgeons really like it to be around 40, 45, even 50%. And they ask, can we do an ablation? And our advice is a very deep-seated lesion. It's hard to get margins around the tumor. All right, and it's abutting the IVC with heat sink effects that's real. Although if you use microwave, that is probably not so much an issue, but still it is present. So, and for transplant, the wait list is long, and we need to treat this patient, and hence we've gone down to do Y-90 for this patient. So here's the patient's profile, and we've gone, it shows arterial avidity. We've given Y-90 microspheres 300 grays. We're not hitting 400 then because it was before the legacy trial, and you could see that 1 month after implantation, you've got calcification within the lesion, and still some tumoral presence in the anterior part of the tumor. But it bought us some time. The time to do portal vein embolization to the right lobe. Okay, 2 months later, there's hypertrophy of left lobe, which is clearly seen, and the future liver remnant has gone up from what used to be below 40% to 63.5%. And patients subsequently had extended right hepatectomy, and this was followed by post-op MR and then ultrasound follow-up, and shows no recurrence. So it was a good outcome for this patient in terms of using Y-90 to bridge the patient over to resection. Now let's move on to the intermediate stage. So the third change was kind of pushing a little bit more of the severe stage B to stage C. So when you look at, for example, the intermediate stage, they have extended liver transplant criteria based on size and AFP, then well-defined nodules and preserved portal flow with selective access, you go do taste. But diffuse infiltrative disease that's extensive, okay? No portal venous involvement, but just the fact that it's diffuse and infiltrative, you do systemic therapy is recommended, all right? So that's the new guidelines. And that's in keeping with also advanced stage patients with portal venous. You really should be doing systemic therapy for these patients. And azithromycin has proven itself to be useful for some of these patients and showing good results, but not all of them benefit significantly. But certainly, this is something that would be advised to the patient. And if you're not suitable for azithromycin, then the next line will be sorafenib, which is like, you know, we know the effects are not fantastic. Okay, so this is where we're looking at in terms of the later stages. So we have patients that have bilobar and infiltrative disease, all right? And what did we do? So here's just a quick history. Here's a 64-year-old Chinese female, ketogenic Child-Pugh A with liver cirrhosis. And we've got the faint T2 hyperintensity over there. And this is where we did a combined CTase and ablation. All right, and we've gotten good margins, so that's fine. But patient represented like 4 months, April to 4 months later, and now we have lesions everywhere. We've got one is bilobar, you've got one in segment 3, one in segment 4, they're infiltrative, and then a few over in segment 6. So if you look at the chart, it says that let's do systemic treatment, which is fair. But back then, before the trial, before the study, the update, we progressed this patient to Y-90. And if you look at it, what we did was to preserve as much liver function as possible. We used deptase for the segment 6 lesions, and then we use Y-90 because it's infiltrative on both segment 3 and segment 4. And if you look at 7 months post Y-90 and after that 15 months, a little bit of ascites there, but there's involution of segment 3 infiltration lesion and no segment 6 lesions recurrence. And then over time, you could see the patient has improved. And then 3 years later, or 2.5 years later, we're looking at a new T2 signal in the involuted segment 3. So we proceeded gamely to retreat again and gave a reasonable dose to segment 3 lesion. We treated with Y-90 TheraSpheres. And 8 months out, and 11 months out, we could see there's involution of the lesion. And you know, patient presented in 2017 with this appearance. Five years out, and we are able to provide that increase in prognosis for this patient. Polyvenous thrombosis radiation cystectomy. Under the guidelines, is very clear, systemic treatment. Here is a patient that we had, 65-year-old male, Hep C cirrhosis, segment 7 mass with right portal venous thrombosis. As you can see, the tumor is in red arrow, and the blue arrow shows the polyvenous thrombosis. It's likely that there's tumoral involvement given the plum-looking appearance. This is the planning stages that we've done. We implanted the Y-90, and over time, as you can see, you give a big enough dose, there's involution of the segment. The portal vein no longer shows any enhancement or any presence of tumor, and you know, patient out for close to 2 years out, doing fairly all right. And up to August, July, patient was well. You could see the posterior sectorial and the part of the anterior sectorial is significant involution. There was a new recurrence, but at that stage, patient had invasive ductal carcinoma of the breast. This is a male patient, by the way, with axillary lymphadenopathy. So decided to do hospice care and not follow up. So coming to the end, my time is up, just nice. Our approach primarily is still largely, if it's less than 3 centimeter, we'll still go for ablation. And if it's 3 to 6 centimeter difficult location, we do a CT and ablation because Y-90 is costly. Up to 8 centimeter, if you're going for curative, we'll do a high dose Y-90. Of course, given the new BCLC guidelines, these are interchangeable based on patient factors, customizing your treatment to the patient. And of course, the ancillary are like if it's multifocal or up to 7, we're looking at palliative, either adaptase or Y-90. Patients for transplant, we're looking at Y-90 because it's longer time to progression versus CTase and adaptase. And high intermediate stage, we do palliative Y-90. Thank you.
Thank you very much for your very excellent presentation. So, như quý vị đã biết thì là trong cái vấn đề trong cái bài talk của giáo sư Lawrence thì chúng ta biết là hiện tại về vấn đề điều trị ung thư gan thì chúng ta đang ở trong cái kỷ nguyên của thuốc toàn thân. Chính vì thế nên là hiện tại thì cái concept điều trị về ung thư gan đã thay đổi rất nhiều từ cách đây khoảng độ 10 năm rồi 5 năm rồi cho tới hiện tại. Chính vì thế nên là cái vai trò của điện quang can thiệp đã thay đổi rất nhiều, và qua cái bài báo cáo của giáo sư Lawrence thì chúng ta thấy rằng là cái vai trò của điện quang can thiệp nó cũng đã cạnh tranh rất nhiều, nhưng mà với các cái phương pháp mới, đặc biệt là với vi cầu phóng xạ thì có thể áp dụng được một số các cái chỉ định, thay đổi một số cái chỉ định trong điều trị. Chính là đấy là một cái điều, cái key rất là quan trọng. Giáo sư Lawrence sau bài báo cáo này thì lại quay về nước luôn. Chính vì thế nên chúng ta cũng tranh thủ thì chúng ta đặt các câu hỏi, còn các cái bài báo cáo sau thì chúng ta sẽ để đến cuối phiên chúng ta thảo luận. Thế vậy thì trong hội trường chúng ta thì có ai có câu hỏi gì dành cho giáo sư Lawrence không ạ? Trong quá trình vậy thì mọi người đã có hỏi thì tôi cũng hỏi luôn. Thank you very much for your presentation.
Thank you.
So we agree with that. Now we are in the area in the era of oncology field, oncology. Now we know that the concept of ACT treatment should trend because oncology now can apply in many stages of HCC.
Yes.
So we agree with that, and we know that the radiation treatment is the new weapon for the ACT treatment.
Yes.
And we apply the SIRT scene, I think that 10 years ago.
Yes.
And we only use the third sphere. And now I understand that your practice you use the terasphere, right?
Actually, we used both the compounds. We started our practice using spheres, and we were proctored, and then after that we moved on and used TerraSphere because Boston Scientific bought over, can't remember what the company was, and then came over to Asia and decided to set up. So we used TerraSphere. So there are benefits to both, so to speak, because the sphere plant is in Singapore, so you can get access immediately. whereas for TheraSphere, we have to wait about 10 days for the dose to come in. Now, the reason why we use TheraSphere is because when you're doing radiation segmentectomy, they were the originators of using glass microspheres to do radiation segmentectomy, and we kind of followed what the literature showed. We spoke to the experts in North America and followed their way of doing. And certainly, we got used to using TheraSphere for delivery. But if we are looking at doing a lobar treatment, meaning that we are looking at doing palliative work, we need more microspheres. And in that sense, resin microspheres is what we will use. So we actually kind of use both compounds. If it's radiation segmentectomy, more TheraSphere. But there's recent evidence out there, was just published either this or last year by Kokabi, and basically showed that the results for radiation segmentectomy resin microspheres is just as good. So both can be used for radiation segmentectomy, so there's no bias towards one another in terms of literature. But in terms of practice, we tend to use more gas microspheres for radiation segmentectomy, and also, but using resin more for palliative lobar infusion.
Thank you very much. And we know that for the radiation segmentectomy, I think that the anatomy of vascular is very important. So my question is now, if we have the tumor, if there are multiple supply feeder,
yes.
how you can?
So yeah, so like if it depends on what we're looking at. Certainly, you do have to map it correctly, ensure that the tumor is within the segment that you want to treat. If there's a crossover to another segment and you're taking up more than 2 segments, then you do have to look at the patient's liver function. You can elect to go ahead with the radiation segmentectomy, but understand that on the periphery of the lesion, if it's not too big, you can combine it with ablation, or you can, if the cost is too prohibitive, you can take that back and just do depth TACE for that patient. All right, but it depends on where on the BCLC scheme the patient is and how many nodules there are and how big it is, right? Because if you're on an intermediate stage, then it's a bit different.
Thank you very much. Như một số các cái bài báo cáo của các cái diễn giả hoặc các cái bài báo cáo của quan điểm của chúng tôi rằng là điều trị ung thư gan nó phụ thuộc cực kỳ nhiều vào kinh nghiệm. Chính vì thế nên ngay cả cái chia sẻ của ông thì chúng tôi nghĩ rằng là rất phụ thuộc rất nhiều vào kinh nghiệm, chứ không có một cái lý thuyết gì một cách là cố định cả. Trong hội trường chúng ta thì có ai có câu hỏi dành cho giáo sư không ạ? Vâng.
I have a question for you. You do the interventional radiology, and as you know, the surgery sometimes is a curative treatment for the HCC. And in the case of FLR insufficient, you do the portal vein embolization. And how you think about we do portal vein embolization combined with the hepatic vein embolization in the same time?
Yes. So this is a hepatic venous deprivation, and certainly when you do portal vein embolization, just as on the conventional basis, they are looking at the liver growth within 2 to 4 weeks. Actually, kind of like the surgeons are very keen to get operating very quickly after portal vein embolization. Embolizing the hepatic veins with hepatic venous deprivation helps to encourage the growth of the liver remnant a lot faster in the left lobe. We've done a few patients, but our results haven't been that stellar. And I think primarily because we've come in from the jugular side. If you look at the Swiss study, Boris, he comes in from the peripheral side, and he's quite brave. He blocks off, and then he gives a lot of glue and embolics and liquid embolics, and that goes out and covers the peripheral aspect of the liver, because there's a lot of cross flow between the portal veins. But that is, to us, a little bit kind of advanced in terms of we are worried that it might flow back into the heart. So we've not really tried that, but there are 1 or 2 cases out of like the 7 or 8 that we tried that worked, but not all the cases kind of work for us in a big way. But yes, hepatic venous deprivation, embolizing both the portal vein as well as the hepatic venous is a good technique to encourage faster future liver remnant growth.
Thank you very much. Bởi vì trong thực tế thì các cái phẫu thuật cắt gan này vẫn là kinh điển trong một số các điều trị triệt căn của ung thư. ung thư gan biểu mô tế bào gan HCC, nhưng một số trường hợp thì bệnh nhân có trình phẫu thuật nhưng cái thể tích gan còn lại không đủ, thì như ông cũng trình bày là cái nút tĩnh mạch cửa, thì cái này chúng ta cũng làm được lâu rồi. Nhưng mà gần đây nhất thì chúng ta tiến thêm bước nữa là chúng ta nút tĩnh mạch cửa và tĩnh mạch gan cùng một cái thời gian, thì cái việc tăng thể tích gan nó nhanh hơn rất là nhiều. Trước kia chúng ta phải đợi 4 đến 6 tuần, bây giờ có khi 2 tuần, 3 tuần thể tích đã đủ rồi để mình chạy đua với cái chuyện là cái ung thư nó không tiến triển, hoặc nó không di căn đi xa. Thank you very much for your answer. Nếu các bạn còn câu hỏi gì thì không, nếu không thì sau đây thì ông thấy trở về nước luôn, cho nên mọi người có câu hỏi thì mình cứ đặt câu hỏi luôn. Xin mời. Ok, thank you. Không có sao chị à? Thank you very much. It's okay.